How are you? I hope you guys are enjoying your breakfast at this first annual, maybe more than annual, but we wanted to get your opinion on it. We made this podium because they needed to build something for short Japanese guys to come up here and talk to you guys. So that's why I'm so high. But I'd like to welcome you. My name is Hugh Kudama. I'm the Vice President for the South King region for Multicare Health System. I've been with Multicare since 1993 and been in the South King area since 1998. In fact, the reason I was up here was our EPIC, which is our electronic medical record. We brought it first up in Auburn, so there's a natural affinity that I have personally with Auburn because it was such a great experience. First speaker is Shalene Whitaker, who is from the Washington State Hospital Association. Shalene is responsible for a variety of policy issues at the Washington State Hospital Association, including the implementation of healthcare reform and the insurance exchange, mental health, and federal policy and advocacy. Shalene started a career at WSHA in 2013 through an internship with the Washington Coalition for Insurance Parity. And the coalition successfully advocated for the state's mental health parity law, and she played a significant role in the enactment and subsequent expansion of the law. Shalene earned a Master's in Health Administration and a Certificate in Health Policy from the University of Washington, in addition to a Bachelor's of Arts in History from the University of Washington. So if you join me in welcoming Shalene to the stage.
So before I get started, I wanted to ask, how many people are from a small business of less than 50 employees? With more than 50 employees? Great. So covering the uninsured is a major goal of the Affordable Care Act. And this slide here is talking about the Hospital Association. We are actually an organization that has 97 hospitals that we represent across the state. We are a trade organization that has come together with the idea that we can, by working together, we can accomplish more. So we represent hospitals in front of the state legislature and regulatory bodies. And then we also provide direct services around public policy analysis, hospital board member training, disaster readiness, and then we also have an award-winning patient safety program. So this slide is meant to frame what the changes are coming in 2014. And in Washington State today, we have between 800,000 and 1 million people who are uninsured. And this was recognized as unsustainable for our healthcare system in many ways. And so the Affordable Care Act, when it is fully implemented, it will be the largest reduction in the number of uninsured since Medicare and Medicaid was enacted back in 1965. What the law does is it builds on the employer-based system. So it maintains this system as the basis for the law. And then Medicare and Medicaid programs for people over the age of 65 and for people who have very low incomes, those programs are maintained as well, and in fact, Medicaid is expanded. So the 4 ways that we're going to see the number of uninsured reduced in our state are through subsidies through the health insurance exchange that Pam will talk about in more detail, and then the Medicaid expansion, which I will talk about what changes are coming through that expansion in 2014. And then also, the law includes 2 provisions around the individual penalty and the employer mandate. And these are both designed to make sure that people have insurance either through their employer, or if they do not have coverage through their employer, that they will be paying a penalty if they remain uninsured. So there's a lot of misinformation out there about the Affordable Care Act, and I think this slide illustrates some of the misinformation and also what information is not getting to people. So 42% of Americans are unsure of whether the Affordable Care Act is the law of the land. This is based on a Rural America poll. And there's also lack of awareness. 78% of the uninsured do not understand that they may have subsidies available to them through the exchanges, and 83% of the uninsured are unaware of Medicaid expansion. But the good news is the uninsured do recognize that health insurance is important. It's important for a variety of reasons, including some of the things that Hugh talked about and achieving access to primary care and to help prevent conditions that could be worse and end up with more costly services down the road. We want to keep people healthy. So who are the uninsured in our state? Well, they are people with very low incomes who are often the working poor. So you can see on this slide that nearly 400,000 of the uninsured in our state earn less than about $11,000 a year. So 100% of the federal poverty level equals $11,170. So if we look at the slide, if you can see between 200% and 300% of the federal poverty level, there's another 110,000 people. So those are people earning incomes. I'm quoting incomes for a single individual. People earning incomes between about $22,000 and $33,000. So most of these people will qualify for Medicaid expansion in 2014 or for subsidies in the exchange. But before I get into that, I want to talk briefly about the individual penalty. In 2014, if you are uninsured, you will pay a penalty of either $95 or 1% of your income, whichever is greater. This grows to 2016 to $695 or 2.5% of income. So this means for somebody earning $35,000 in 2016, their penalty will be about $875. If someone's earning $60,000 in 2016, their penalty will be about $1,500. And the penalty will be reconciled when a person files his or her taxes. So that Internal Revenue Service will be the one that will be administering this penalty. Additionally, you will be penalized if you do not have coverage for the full continuous 12 months. So you'll pay that penalty if you have a lapse in coverage. And those are annual penalty amounts, they're not monthly penalty amounts. The other way that the law aims at maintaining the employer-based system is through the employer mandate. And this says that if you are a company that has greater than 50 employees, that you need to provide your employees affordable coverage, and the coverage needs to have a minimum value. So what this looks like, does anybody know what an actuarial value is? Oh, there's some, oh, you guys are good. Well, I know you do, Pam. The last audience, no one raised their hand, so very interesting. The actuarial value is a way to measure whether or not how much the health plan is going to be paying for estimated costs for healthcare services versus what the employee will be paying. For example, employers starting in 2014 will need to have a minimum actuarial value of 60%, meaning that on average, costs are estimated for your enrollees, your healthcare costs, and the plan will be paying 60% of those, and the employee will be paying 40%. So that's the minimum value for employers. The other piece is around the affordability test, that employers will need to have health plans that are less than 9.5% of an employee's income. So this needs to be affordable, about less than 10% of their income needs to be going to health coverage. So that, again, comes into effect in 2014. So you can see that these are the penalties on the right-hand side for not having those affordable coverage or not having minimum value. So our state is poised to adopt the Medicaid expansion, and what this looks like is that many more people will qualify for this program. This is a state and federally administered program. And right now, in order to qualify, so in 2013, the restrictions are pretty significant. It means that you have to be low income, meaning you have to earn less than $8,000 a year. and you need to have a qualifying factor. So you need to be either disabled, be pregnant, have a child, or be over the age of 65, and be low income to qualify. So in 2014, this changes significantly. What happens is those qualifying factors, the ones that I just mentioned around being over the age of 65 or being pregnant, having children, those are removed, and eligibility for the program is solely based on income. So that income standard is almost doubling to $15,000 a year. So it's going to be based on modified adjusted gross income that's determined by the Internal Revenue Service, and this will be the new way that Medicaid is administered. So, and the other piece I'll just say is that for children who have living with a family that has an annual income of less than 300% of the federal poverty, there's no change to qualify for the Children's Health Insurance Program. So in 2014, that will not be changing. Our program will remain the same in terms of children's coverage. So this is significant, as I mentioned, a significant change in the way Medicaid is administered. And what it means is that there's an estimated 325,000 people who will now be eligible and will enroll in the program. These are people who are earning less than 138% of the federal poverty level. So that is about $15,000 for a single person and about $32,000 for a family of 4. The other way that people are going to have access to health coverage is through the health insurance exchange subsidies. And through the Affordable Care Act, individuals and families earning between 138 and 400% of the federal poverty level will now be able to be qualified for federal subsidies and be able to shop for commercial health insurance through the exchange. And Pam will talk a little bit more about this in a minute. So that means someone earning between $15,000 and $45,000 will have these subsidies available for them. And remember back when we were talking about who the uninsured are in our state, you can see the majority of the uninsured earn below this 400% of the federal poverty level amounts. So this is going to be, again, a significant change in the way that healthcare coverage is obtained by people, and we expect about 200,000 uninsured to enroll through the health insurance exchanges in the next few years. So this map is a little bit difficult to read up on your screen, but I'll tell you what it says for Pierce County. This is measuring the number of uninsured who are eligible for Medicaid beginning in 2014. And this says that about 25% of uninsured in Pierce County will be eligible for Medicaid. The next slide shows that the number of uninsured who will be eligible for subsidies. So this is going to be a greater amount of people because the income qualifications, as we just talked about, 138 to 400% are going to be going to capture more people. So this slide shows that in Pierce County, about 45% of the uninsured are going to qualify for subsidies. So this is the Washington Healthplanfinder website. This is brought to you by the Health Benefits Exchange. And this is the website that will be available to consumers to, on October 1st, to enter their income information, actually enter their personal information, to enter their social security number. You need to have a check to see if you are a citizen in order to qualify for the programs that I just talked about. And in real time, you will be able to get a response back around if you qualify for Medicaid or if you qualify for subsidies in the exchange. And the exchanges were created as a way for individuals to shop for health coverage and for small businesses. And I'll talk a little bit more about small businesses, and then Pam can follow up as well. As I mentioned, that website was the way that consumers are going to achieve access to those programs. This slide depicts what the back end looks like, what the consumers don't see. They'll come to the exchange website, the healthplanfinder.org. They will enter their information, and then on the back end, you'll see that they will either be directed to Medicaid, which is regulated by our state healthcare authority, or they will be directed to shop in the insurance exchange, which continues, health plans continue to be regulated by the Office of the Insurance Commissioner and will be certified for participation by the exchange. So people between 138 and 400% of the federal poverty level will be subsidized, but people who are earning incomes greater than 400% of the federal poverty level will also be able to shop for health coverage in the exchange. We heard recently that health plans did not want to participate in the small group exchange. This is for businesses that have fewer than 50 employees. There's going to be a pilot in some of in the county to the south, but for Pierce County, there will not be a small group insurance exchange for 2014.
What about King?
And not for King either. So none of theirs, only in Clark County. So why I bring this up is that if you go to Google and you enter Washington Insurance Exchange, the Hospital Association website pops up as one of the top sites. So I get a lot of interesting phone calls and emails from people, and one of the ones that I've been getting a lot lately, I've received a couple in the last few days, are from businesses saying, I understand that there's not going to be a small group insurance exchange, and I've been with Regents for 25 years, and does this mean that I can't have Regents cover me and cover my employees anymore? What does this mean for my small business? And really what it means is there's not going to be a change in how small businesses purchase insurance in 2014 for the majority of the state, that you can continue working with health plans that offer those products to your small business the same way that they offer them today. They'll be offering them in 2014. So this is really not a change. I think it's getting reported in the news as what it is, what it's not going to be, but what the media is not saying is that it's really maintaining the status quo for the time being.
So can you explain what it is? What it is? What is it? You told me that there is no change, but you mentioned it, and I'm still not clear what it means that there's not going to be any small group exchange.
So if I'm a small employer, I would purchase my health coverage outside of the exchange as I do today. So I can continue to work with Regents and purchase a health plan for my employees and my small business the same way that I do today.
I understand that, but you said in Pierce and King County there won't be something. What is it?
There won't be a small group insurance exchange, meaning that small businesses will not be able to go to the website, the Healthplanfinder website, and compare plans.
Okay.
As was intended by the law. And Pam can talk a little bit more about why they think that small businesses do not want to participate in the exchange, or small group health plans offering small group products. So thank you. So last slide, one piece of information here is around how the law is paid for. I think there's a lot of misconceptions about this. You hear a lot of people talking about the Affordable Care Act that's contributing to the deficit. The fact that the law is paid for over 10 years, and it's paid for in part by one of the hospitals, the hospital staff that are sitting in this room. Hospitals are taking significant cuts to pay for those coverage expansions that I just talked about that are coming through Medicaid and through subsidies in the insurance exchange. In Washington State, our 97 hospitals are taking cuts of nearly $4 billion over 10 years to help pay for the law. There's also a tax on health plans and an increase on Medicare tax for high income wage earners. There's also a tax on medical device and pharmaceuticals, and the common one that people know about is a tax on Cadillac health plans, the ones that have very rich benefits. There's a tax included on those plans. And last but not least, tanning services. So that one is often forgotten about, but I like to mention. So those are the ways that the Affordable Care Act is paid for over the next 10 years.
Thank you, Shalene. So next we have Pam McKuen. Now Pam is the Chief of Staff for the Washington Health Benefit Exchange. And prior to joining the leadership at HBE, Pam served as Executive Vice President for Public Affairs and Governance for Group Health Cooperative. She directed Medicaid and Medicare programs, performance and strategy, government relations, public policy, communications, and consumer governance, serving on Group Health's leadership team for 16 years. So she has a wide range of experience. And previously, Pam served as commissioner with the Washington Health Services Commission implementing the Health Services Act. She worked with a broad coalition to pass healthcare reform legislation. She served on several health policy initiatives in the public and private sector, chairing the Association of Washington Health Plans and serving on the Washington State Hospital Policy Committee, the King County Health Action Plan, and the Children's Health Initiative. She holds an MAT in history from Brown University and a BA in economics from the Evergreen State College. Pam?
Thank you. Thanks very much, and it's a pleasure to be here. I wanted just to note that we actually started the 100-day countdown to go live, which we're all, so speaking of a blink of an eye, this is going to all be here before we know it. And I presume you're here because you're interested in what a big impact this is going to have on healthcare for all of us, whether we're covered by the exchange, we have loved ones who are interested in the exchange, whether we run a small business, or even a large business that is self-funded. There still will be impacts felt as these changes kind of hit our market. I think Shalene did a fantastic job of taking you through the Affordable Care Act, but I like to kind of say there are two important things you need to remember about the Affordable Care Act. It reformed insurance significantly. For the health plans in our state, they will be doing everything differently. They had to refile all of their individual offerings and small group offerings, whether they're in the exchange or not. A huge undertaking for a health plan. And then they are regulated really in every aspect of their business, kind of in a different way. And so it's been really a year of retooling for these health plans. But on the other end of it is consumer protections that did not exist before. So kind of the end of lifetime limits. Our children under 26 can now be on their parents' policies. In terms of benefit coverage and rate approvals, all of that came through quite differently, creating a really different level playing field for consumers. The other half of this is expanding coverage, and Shalene talked about this really eloquently. Coverage expansion is going to happen through subsidies that go through the exchange to families up to 400% of poverty, and then the exchanges are available for individuals and small businesses to buy into individually. And then Medicaid is going to be expanded greatly up to 138% of poverty, and no longer categorical requirements. You just need to pass the income test to be qualified. So here's how the exchange works. Here are kind of the fundamentals. So the exchange is really targeted towards those individuals over 138% of the federal poverty line, and providing subsidies through tax credits up to 400%. And it's interesting to think about, what does that look like? For a family of four, can be earning upwards over $90,000 a year to be in that category of 400% of the federal poverty line. So these subsidies start to really work their way up into really middle-class families to be available. The subsidies at that high end are not going to be as much. People at the low end, who are just over 138% of the federal poverty line, will be paying somewhat like $20 a month for their health care. People at the high end will be paying almost the full amount, but they will still have that additional help. And what I like to say is that people have not purchased health care because they didn't want it. They didn't get it because they couldn't afford it. So all of a sudden you have a market where you never had a market before. You have people who have the capability to buy something, and you have health plans coming to the market offering to sell. So it kind of creates a lot of buzz and a lot of change. For people who are really low income, below 250, they will also have cost sharing. So all those costs you pay when you go to multi-care or any healthcare facility, kind of out of your pocket that you weren't expecting, those very low income families will have assistance for those charges as well. And then the other big change, and this kind of gets back to the insurance reform, is the 10 essential benefits. And for a long time, because of the price of health care and competition and trying to get people to stay in the market, people have been really kind of paying more for less. And health plans have been engaged in what they call benefit buy-down, which is kind of pulling the benefits out. Your out-of-pocket costs go up, but your premium price remains affordable. But when you go to the doctor, there's a lot of bad surprises about what's covered and what's not covered, and what you have to pay out of pocket. The 10 essential benefits start to create a kind of a comprehensiveness in health care, so that consumers can feel confident when they go to the doctor that what they need will be covered and that they can afford it. This is going to be a really big change, but we were very surprised though when the rates came in from the health plans that despite having to cover so much more of the benefits, the prices did not go up nearly as much as we thought. They went up a little. Some cases they even went down. Qualified health plans and qualified dental plans are another part of insurance regulation. Health plans to be offered on the exchange will have to be approved by the OIC, the Office of the Insurance Commissioner, certified, and then approved by the Board of the Health Benefits Exchange. There are 19 criteria that they have to pass. Some of them are very basic that you would expect any reputable business to be able to pass, and some of them are quite specific, having to deal with network adequacy and the ability to prove that you have doctors located throughout the counties that can serve people. So we're going through this process right now as we speak. Staff at the OIC are working massive amounts of overtime to get these plans approved. And then the metallic tiers of actuarial value. I'm glad Shalene introduced the actuarial value concept. Again, this is to create consistency and transparency in the market so people know exactly what they're buying. And they're what we call metallic tiers. And that's just like the Olympics, or platinum, gold, silver, bronze. And they tie to the actuarial value, so that I believe the platinum is 90% of costs are covered by the health plan, silver's 80, bronze is 70, and kind of on down. This again, it gives a sense of I know what I'm paying for, I know what's covered, I can compare apples to apples when I'm shopping. And then the other part of this is that enrollment is going to be incredibly important. But as much as I think about healthcare every day, the people who work in hospitals think about healthcare every day. People who don't have coverage are not thinking about this at all. They haven't had coverage. They don't really understand what's happened. The Affordable Care Act has been confusing. They don't know this is out there. And we've done surveys that unfortunately show this to be very true. So there's going to be a massive outreach effort really starting over the next couple months. And it's going to be backed up by a lot of in-person assistance. I don't know if people remember when Medicare when Part D came into Medicare, that was pharmaceutical coverage. And whether you work for a healthcare provider or you have somebody in your family who was over 65 who just went bonkers trying to figure out what the new system was like, there was no help available for people. I'm hoping the federal government learned their lesson on this. And this one, they are actually providing federal money to provide assistance through people who will be ready to help. And these will be in communities. We've contracted with 10 different organizations regionally throughout the state who will work in communities to connect with other organizations to reach out and help people enroll. And not everybody has a computer, not everybody's comfortable using a computer. This actually somebody will sit down and walk you through it. This also enables hospitals and healthcare facilities to connect into those systems, to work with navigators and in-person assisters, and even have some of their own staff kind of ready to enroll people. So this is going to be really important. I just wanted to note that the reason our state is so far on the front, and I think we're one of 3 states that is really most ready to go live on October 1st, is because a lot of policymakers in our state had tremendous foresight about this. And in 2011, they passed legislation before they knew what was going to happen with the Supreme Court to initiate a planning process and to put together a board for our exchange. So that in 2011 and 2012, our state went through a very detailed, comprehensive planning process to build the exchange and was able to apply for the federal grants that were available for state exchanges, receive that grant funding, and hire staff and really build a functional exchange. So that we actually are at the point where we are testing the systems for our exchange. We're very lucky in this regard because I think a lot of other states are really scrambling to be ready. And 2013, this year, we should be able to go live on October 1st, and in 2014, people will actually start to be covered. This talks a little bit about the individual and the shop exchange, kind of who's covered. So I think I've gone through kind of who's on the individual exchange and what they get access to, and what open enrollment is going to be beginning on October 1st with some special enrollment. That's something I want to note, which is that Open enrollment ends at the end of March. It's a very long period, October 1st to the end of March 2014. But if you miss open enrollment, unless you have a qualifying event, what's called a qualifying event, like having a baby or moving or losing your job, you can't get covered after that time. And that's an astonishingly difficult concept to get across to people, particularly young people or people who feel immortal or I don't feel sick now, why should I sign up now? So we're going to be working very hard to educate people about what an open enrollment period is. And even though they have a lot of time to sign up, I'm really afraid that people are going to miss this, and we're going to hear from people in May or June who have discovered some terrible health problem and find they can't get coverage. The SHOP exchange Shalene talked about, there were some questions about. SHOP is for businesses with fewer than 50 employees, and it enables small businesses whose employees are paid at a lower level to access tax credits and to shop on the exchange and have some additional buying power through kind of aggregating businesses on the exchange, and also to give employees additional choice when they shop on the exchange. In our state, for a lot of reasons we probably don't have time to go into now, the large health plans were not interested in bidding on the exchange. We have many small businesses who wanted to buy, we're very interested, but we have nothing we can sell them because the health plans were not interested in bidding. And we have, we're right now in the process of interviewing health plans, finding out what's wrong, what their concerns were. We have a complicated small group market here that's going through a lot of upheaval, and my personal opinion is it was too much change for the plans, and they were concerned that they would lose some competitive advantage by coming into the exchange versus the outside market. So we're working with plans now and small businesses to be ready to go in next year, for 2015. What we are doing is we are able because of Kaiser's interest, Kaiser is one of the largest plans in Oregon, and they are really interested in serving Clark County. And so we will be able to run a pilot with them in Southwest Washington and be able to test out the exchange for small business, so we're ready to grow that the following year. The exchange value proposition, I think, is, this is really important, is the idea of no wrong door. You don't have to guess where to go. You don't have to think about who to call. You go to the Healthplanfinder website, no matter what your income level is, you can shop and you will be directed kind of seamlessly and invisibly to your right program. So if you're very low income, you will go right to the Medicaid programs. If you're higher income, you will be informed about tax credits, and if you're higher than that, you will just shop amongst different health plans and be able to compare them. There's an idea of knowing what you're buying, being able to compare products, to make something that has been an overwhelming experience be less overwhelming. And then there's an ability to compare and shop, which we take very seriously. Once people choose a health plan, they tend not to change. And we want people to be able to have the tools when they're shopping and using our website so that they make good choices. For the publics, the uninsured have cost us all a lot of money. And what we're hoping with the theory of the hospitals is they did lose some money, but we're hoping that they have a lot more paying customers in the future, and uncompensated care begins to be something of the past. We should see an improvement in wellness and population health as people have access to care. And we should see a more competitive marketplace. We are, as I said about patient choice, we are providing tools on our website so that people can sort by their interests, by what they want, by where they want their doctor to be, what language they want their doctor to speak, by which providers that they want to go to in their community, and start putting in those preferences and look at the health plans that offer those and compare those plans. And this is what it looks like. It's a little more complicated than buying a ticket on Travelocity or buying a product on Amazon, because we have to interface with the IRS so that we can figure out your tax credits, and I don't think Amazon or Travelocity do that. But otherwise, it should be a pretty familiar experience where you go online and fill out the form, and then you indicate what you're interested in, and health plans will pop up. And you have an option to sort them by price or by what you're looking for, and shop around, and then make a choice based on these factors, and then you choose. You can choose by, you can look by healthcare provider. I actually think that's one of the single most important things people have when they're making a choice about healthcare. And here's another way you can compare plans, just like consumer reports. I wanted to note, I think this is important for, I know we have some small business people in the audience, is that brokers are an important part of this. We are going to have in-person assisters and navigators to do that outreach that's so important. But a lot of people are used to going to brokers to make their choices. And brokers can take a more proactive role in actually helping choose a health plan, whereas navigators are really supposed to help you use the system and make your own selection. If you're someone who wants someone to sit down and pick the best thing for you, a broker is the best person to do that. So you can indicate your broker on here, and then the health plans will, pay brokers a commission just like they do on other individual choices. Do you have a question?
Yes, ma'am. Are consumers going to have the opportunity to write reviews like they do on Amazon?
Well, that's a really good idea. There is going to be a chance to find out. As the first year, we're going to take a lot of consumer feedback about complaints and issues like that. We don't have that capability on the website yet, but I think it's a really great idea. We are going to have like star ratings, and we're looking at right now, what that's going to look like and how that will appear on the screen. We don't have anything to rate now because it's our first year, but our second year we'll be able to show those ratings. And the idea of having some consumer feedback is a really great idea. Yes?
Is this website available in other languages? I see your service
Yes.
languages are available, but...
It's available in Spanish and English. And then if you speak another language, there'll be kind of flyouts that tell you what languages are available, but you will have to call to do that. We could only translate the site into 2 languages, but you can call our customer center, our call center, and there will be people who can translate into any language. So here's kind of issues that we're dealing with now, which is, again, building up the in-person assister and navigator program, getting those people trained right now. We are working on our we have to be financially sustainable by 2015 and needed to pass legislation this year. We're hoping that happens today, so we'll see. It's part of the budget, and so we've kind of gone right down to the wire on that one. And then we're dealing with offering adult and family dental benefits. We don't have adult benefits this year. We're hoping to have those within the next 2 years. And then, of course, quality measures and working with our board. We have an excellent board, by the way. It's a bipartisan board that was appointed between legislative nominations and the governor, and was meant to spread the political gamut. And I've worked in healthcare policy for a long time, and I know that things tend to hold better and last longer if you can work on a bipartisan solution. So I really appreciated what our board has brought to the table. Our challenge is that we have a very ridiculous tight timeline. So there's no way you would typically try to build a program of this complexity in the timelines that we've had. But we're doing it, and it's going to be a great service to people to have this care. We are very dependent upon other agencies within Olympia in an environment where people haven't worked always that cooperatively, so we've really had to change the way we work with the other agencies that deal with healthcare, and have come just miles and miles in that regard, and how people work together. And managing expectations. This is the first version. The first version will do what it's supposed to do. We will get people enrolled. It will work well. But a lot of the enhancements can't come until future years. And we're already starting to build our list, which we call version 2 and version 3, to start thinking about what those enhancements will be. And for more on the exchange, I would encourage you to look at our website and really kind of explore around. The exchange is covered by the Open Public Meetings Act. Everything we do is completely transparent. Every document we've ever discussed is available online if you want to look at that aspect of it. You're also free to explore the consumer-facing website.
Can I open up for questions?
A couple of clarifying questions. I think you said that they must be a citizen of the state of Washington. Do we know what that test is?
So, in order to qualify for the Medicaid program and for subsidies, you must be a citizen. So, you need to enter your social security number, and the website that I showed you, the Washington Healthplanfinder, your information will be sent to a federal hub, and it will be verified by Homeland Security. Legal residents in our state will also be eligible for Medicaid after they wait 5 years. They'll be eligible for subsidies in the exchange from legal residence.
So you're talking citizen of
Citizen of the
United States,
States.
Washington. Okay.
Yes.
And then it appears through all this that essentially everybody should be covered.
You know, that's a really good question. The reports that I have seen from, you know, who's going to enroll in Medicaid, who's going to enroll in the exchange, there's a misconception that everyone will have coverage. There are going to be people who have to pay the penalty, maybe because they can't afford it, maybe because they don't want the government telling them what to do. You know, so there could be a variety of reasons why people choose to pay the penalty. Also, you know, undocumented people do not have coverage through this. So estimates that I've seen show that about 75% of the uninsured will be reduced through these programs, but there will still be uninsured in our state. Good question.
Question here?
So when you said that the 60% of the employer has to pay towards your insurance costs, were you speaking specifically to the employee, or does that include the family?
So my understanding is the affordability, well, the minimum value is the employee.
Yeah, I think so.
Okay, there's been some questions about that. That's, you know, I work for hospitals. I don't necessarily know exactly some of how these details play out from the employer standpoint. I think that is the question around what is that affordability test and how that works.
Like currently, right now, at a company, let's say I have obviously I have a job, but my employer pays 60% of my insurance, and so my payment is like $100 and some odd dollars, period. But to add my family, it's like $400 on top of that. So that's obviously greater than. So my portion is greater than 40%. So that's why I'm curious.
Yeah, there's a difference there. The affordability test is based on your income, so it's 9.5% of your income. And then it's saying that the employer, what's offered to you, not what you're paying for, but what the coverage benefits are offered to you, the health plan needs to be at a 60% actuarial value, meaning the plan pays 60% and you're responsible for 40. So it's, I think that the concepts might be confused a little bit.
Yeah, benefit that they pay.
I don't know, this is, one of the things that I think is, can be sort of a problem for some families is that if you have good employee coverage at your plan, where you work, you're not allowed to go to the exchange. But that only covers you, it doesn't speak to your family. So you may be paying a lot out of pocket for your family because they're not on your employee insurance, but you still are prohibited from going to the exchange in that situation.
That's what I wanted to know.
Yeah, that's been very controversial because that's going to cause some hardship for some families.
Yes. So what is the percentage that would be too much? Like, say I made $2,000 a month and we pay 33% in taxes, and if we're paying 25% for healthcare, that leaves an employee with like $1,000 to live off of a month. What would be the percentage that the insurance would be of their check to exclude them from that to be able to go to the exchange?
I don't, do you know?
Well, I think that what it's saying is that whatever the health plan, what it costs you in terms of your percentage of what you're paying cannot be greater than 9.5% of your income.
But that's just for me, not the whole.
That's right.
For you.
So essentially at the end of it, if the family costs $800 a month, then you're just up that creek.
Yeah, I think that's what we're going to see play out. Yeah.
I just want to make sure I'm clear. For example, if I work for a company that provides me a qualified plan, and it's reasonable for me and I buy in, but it's unreasonable for my family, I can't go to the exchange. Is that correct?
That's correct, because you're not, the exchange is set up so that people who have employer coverage don't come to shop for a better deal or drop their coverage. You're supposed to stay with their employer coverage. I think it was an oversight to not take into consideration the cost of family care. I think there was some kind of I'm assuming there was an assumption that people who have good employer coverage also includes their families. That's true a lot of the time, it's not always true.
Are you saying the families can't go to the exchange either, or the employee can't go to
Well,
the exchange?
in the United each story is its own story. So I think and sometimes the family could go to the exchange. Like if you have children who are over 18, they could probably go to the exchange. But probably the husband and wife, the couple, they probably could not go. But again, everyone's this is where navigators, in-person assisters, and brokers are going to be really helpful, because different families will have different issues. It's pretty complicated, and I think it's important to understand your own circumstances. When you're advising a friend, you only want to go so far before you tell them to call or get some help.
So before we go to that next question itself, this is one forum. If they have additional questions or other people have additional questions, you say it's individually, circumstances, where could they go for information?
They can contact me if they'd like, and I'll give them answers. So.
Karen.
Yeah, this question needs to address like the access issues that we have. So based upon the data that was presented and the number of people that are now becoming insured, and probably more a question for Dr. Murray, what are we as healthcare providers starting to do to provide access, which is going to definitely, we're going to see an increase in volume of individuals now accessing healthcare. We already have issues with the amount of primary care providers we have. How do we see that playing out?
Thanks. I think the consequences of the law are not only really unknown to us. We can project what they're going to be, but we really don't know until we start seeing people's behavior, business behavior, and so on. And I think it applies to your question as well. But we have to be ready, because we're providers of the care. Right now, the slide that I think you showed earlier, there was a lot of care being delivered without being paid for it, or it was charity care, it was bad debt, it was whatever. So we think that a lot of the health care that will be covered by people who are newly insured, we're already delivering, and we're delivering for free. I personally believe that we'll probably see an uptick in the folks who haven't been able to get insured and who have avoided medical care. In fact, as a primary care doc, we hope that will be true, because we believe in the concept that delivering lower cost primary care to people will help them be healthier and avoid the higher cost catastrophic care, hospitalization, ED. I think the whole bill is based on that principle. So we anticipate there will probably be an increased demand for office-based services, maybe urgent care. I think people who are going to emergency rooms will continue to go to emergency rooms, either because of lifestyle and their perception of convenience, because we can't turn them away by federal law. Not that we would want to, but it's a place you can get care regardless of insurance status anyway, or you're seriously ill or worried that you are. So I'm not personally convinced that the emergency room utilization triggered by the individual patient will change that much. I hope that we'll reduce it triggered by people who get care in office settings. So what we're trying to do with those thoughts as the backdrop are to increase the number of primary care providers we have. We're in the process in our system of changing all of our primary care offices into a type of scheduling. It's called advanced access, where every single primary care provider, every day they're in the office, has same-day capacity built into their schedule. And we're 90% of the way through and converting all of our clinics to that. We think that's an important reality, so people aren't hearing, oh, I can't get in today if I need to get in today. We do have urgent care centers, but we're trying not to get rid of our urgent care centers. I wouldn't want to imply that, but we philosophically believe that patients who've established with a primary caregiver, whether it be a family doctor, an internist, nurse practitioner, or a PA, would probably prefer to see that person if they had the choice rather than a stranger, even in urgent care. So we're trying to make sure that we can realistically offer that to all of our patients every day that we're open. Then I think behind the scenes, there is a tremendous investment in the electronic record. There's a tremendous investment in terms of personnel, in terms of how do we leverage our system that you talked about earlier, so that we can get people to the right care the right way, in the most convenient way. We're creating care coordinators within our office, not navigators for the health plan, but within our organization, so that people can get advice directly. We can reach out to people with more complicated medical problems to make sure that they're not avoiding medical care that would actually help them stay well, avoid the emergency room, avoid hospitalizations. medicine is trying to respond to this idea of lowering the total cost. There's something called the triple aim. I'm sorry, I'm running away from this a little bit, and I'll try and sum up. But for us, maybe some of you have heard about something called the triple aim, which is described about 25 different ways. But the gist of it is to lower the total cost of care for an individual, but for whoever pays that bill. At the same time that you improve the quality of the care that they have, the quality of their outcomes, and their satisfaction with the care. And so it's a noble goal, it's a challenging thing to accomplish. Most of us believe we'll do that by doing more care in the office, less in the hospital. I think the reduction on the payments to hospitals is probably the hope that patients will get care in this other environment. And it's a further inducement to systems like ours to try and get more care out of the hospital. We just think that that's a better place for it to happen, and the challenge for us is to make sure we're effective at it. I rambled a bit. Did I answer your question?
Any other questions?
I did want to say that I feel like what the doctor just called out is really the vision. That's really what we need to get to. And what I would hope is that the exchange and the Affordable Care Act becomes a path that we could actually get there.
Yes, I just wondered if one of our speakers could briefly mention the call center that will be opening up September 1 as an access point to learn more and also enroll.
Yeah, we have a call center that we are opening as part of the exchange. And again, it's one-stop shopping. Anybody can call about any issue. It's being built in Spokane. It's kind of, we felt very important that it be local in our state. And in September, of course, you can't sign up in September, but we figure people will start having questions because they're going to start seeing ads on TV. They're going to start hearing about this in their communities. And they're going to call with some of the really complicated questions that you asked today about their personal eligibility, language issues, special needs issues. So those questions can be dealt with in September, starting right away, so we can start to pick up those questions. And in October, people will be enrolling, and then the call center staff will actually be helping people fill out forms online so that we can actually enroll.
Yeah, one question that somebody sent it to me, is that when will we, the public, be able to look at the plans available in the exchange?
As soon as they're certified and then approved, which probably won't be till the end of August, because I think final approvals come through the exchange board at our August board meeting.
For shopping, it'll be October 1st, right? I'll be able to look at premiums versus tax subsidies, and yeah. One of the things Pam didn't mention on the call center, that they're expecting 450,000 calls in the first 3 months. So,
yeah. And the other thing I want to know is that, I don't know, there's a lot of interest in Medicaid here, but people who have Medicaid issues those are very special, particular kinds of concerns. And sometimes the call center will be able to handle those, so we train to. We can also do warm handoffs to the appropriate state agency so that they get to the right person.
Adrian, I'll give you the last question.
Is dental part of the exchange, dental coverage?
Pediatric dental is.
Only pediatric.
And that was part of the Affordable Care Act. Adult dental won't be available to exchange until next year or the year after, as soon as we can get it in. There's a lot of interest in having dental, so as soon as we can build that, we will.
I'd like to thank you all for coming. If you could help me thank our speakers, Shanice, McKuen, McKuen, and Dr. Murray. Thank you all for coming.